was taken away from Google Photos, and then subsequently they've corrected the algorithm. This is one of those few examples. Quality and relevant data, yes. Majority of the models right now are actually working on simulated data. You feed in the data, it achieves a basic threshold, and after that you let the system keep learning itself based on the simulations it carries out. Whether it's something like I am thinking of something in my own mind and I'm repeatedly thinking about it and then creating a bias towards it. Whereas the actual need is the bias, for the bias to go away, is actual authentic data to come in. There are a lot of unforeseen outcomes that come with these things we have not catered for. One of the examples was in the previous session. So in the other part, now this was an algorithm for the retinopathy. It is supposed to analyze for retinopathy. What it does is it's continuously reanalyzing the similar pictures. The noise starts creeping in. And after a couple of cycles, it starts reading a normal image as a diabetic retinopathy. On the bright side, yes, particularly from the Armed Forces Medical Services perspective, yes, technology can make up for the manpower deficiency. A lot of times we struggle with the early decision making. So once we have the resources in place, this will help in conservation of the resources, especially when it comes to taking decisions like air evacs and management of trauma cases, the kind of resources we need. Increasing number of Indian startups will obviously reduce our offshore data security concerns. Ladies and gentlemen, AI is here to stay, and we all need to embrace it. And I'm going to leave you with these words from Henry Ford. If I'd asked people what they wanted, they would have asked for faster horses. So it's time we need to gear up. AI is here. Thank you.
Thank you, Aman, for such a wonderful talk. I always used to hear that surgeons used to say that AI is not going to never going to replace surgeons. But with his talk, now we are started to thinking that even surgery is not safe from being taken over by AI assisted surgeries. Due to paucity of time, we'll not take any questions. May I request Aman to please accept a token of memento from the organized day.
May I request Colonel Praful Mohan to kindly come up on the stage and felicitate the chairperson? May I request Colonel Vivek Agrawal to kindly come up on the stage and felicitate the chairperson, please? Thank you, sir. For the next session, if you could picture a medical student who is using AI to analyze a patient data in real time, receiving instant feedback on treatment option, and practicing complex surgeries in a virtual world. This is the future of AI-enabled healthcare, where technology empowers doctors to be more skilled, efficient, and prepared for the challenges of tomorrow.
To enrich us, we present to you Colonel Praful Mohan. He is an alumnus of Armed Forces Medical College and has done his DM in clinical pharmacology from AIIMS, New Delhi. He is undergraduate and postgraduate teacher with more than 12 years of experience up his sleeve. He is also a visiting faculty for Transitional Health Science and Technology Institute.
We welcome on stage, sir.
So I hope we all understand that we are a little late in the evening to be too formal about proceedings. So we'll compromise on, in that sense. So can I have the next slide, please? So what we intend to do in this session is call on our esteemed speakers, guests, and panelists who are working in those domains in which AI has already made significant inroads. So first is Dr. Somesh Gupta. The yeah. So I think the fact that he has almost 400 publications itself speaks of his eminence and experience. And when we were trying to curate this CME, we were trying to look out for clinicians who are working with AI or in the fields where AI is sort of ingrained. And whomsoever I asked, Sir's name cropped up, I mean, invariably so. So Sir is there. He'll talk about how his practice in dermatology is getting influenced by AI. Can I have the next slide, please? Dr. Deepika unfortunately could not come. We have a voiceover video PPT of hers. If time permit, we'll play that as well. Next slide, please. And then we have Dr. Subhash Yadav. Please welcome Dr. Subhash. He is somebody who's, again, prolific writer and is a pathologist, and he does a lot of AI-enabled diagnostics, as I've been made to understand. Next, please. And of course, our own Group Captain Rahim. So I think while we call on speakers, somebody can help me with the stage management side by side by putting in more chairs. Can we have just one more chair, please? Because I think Colonel Subhash Shaw is also like to join us. So Group Captain Rahim also is involved in AI NIDUS or a tech NIDUS, which we have in AFMC and ably supported by Colonel Sanyal, whom we have already heard, and also by Arnab Ghosh. Dr. Arnab Ghosh, unfortunately, is not here today. He'll be there with us for tomorrow's session. So next, please. Yeah. And Colonel Subhash Shaw, I would say he's a doctor, gentleman, saint, intellectual, prolific reader, student, all rolled into one. And I'm not going to the nitty-gritties and semantics of all what is there on the screen. That's for all of us to say. So what I'll request is, of all the speakers, I'll call them out one by one. I'm going to moderate this session. I'll sit on that side and request all of them to share their insight as to how AI has, they're all very senior in their own domains, fairly experienced. So how AI has made inroads into their field, into their own domain, how they had to learn certain skills if they had to at all, right, in order to adapt to these technologies, and do they have something to inform us and tell us as medical educationists as to what we should be teaching our students so that tomorrow they're able to adapt to AI or in particular, or technology in general, more seamlessly and more readily. So I'll vacate the podium, sit there, and then we can have this discussion. Of course, we'll try to take, of course, we need to take inputs from the audience, which is by no means less eminent than the speakers. With that, I'll request Dr. Somesh to start, informing us as to what he thinks about that.
Thank you, Colonel Praful. It has been such a day full of learning, and I'm enjoying every moment. And thank you for inviting me to be here. And on quite a few things.
Mic check, please.
Yeah, I learned quite a few things since morning, and it was enlightening in many ways. So as all of you know that the earliest AI came with deep learning models coming in way back in 2017-18, becoming popular and accessible in India. So at the time we started working on image recognition based model for dermatology. So you know that in dermatology, pathology, radiology, or even some part of ophthalmology is heavily based on pattern recognition abilities. And humans, if you read the evolution books on evolution, you know that humans are not good in identifying patterns as compared to our other primates. So, for example, a video, a very viral video in 1990s on BBC television where a chimpanzee repeatedly beating human counterparts in identifying the numbers in a quick time, so on a screen. So that pattern recognition ability of humans has always been, suboptimal. So therefore, the image recognition technologies we thought would be going to a good boost in clinical practice. So we started working on that. And most of the models which were available at that time were on binary classification model. That is, either a skin lesion has a cancer or it doesn't have a cancer. But it doesn't serve our purpose because we don't just see cancers. We see many patients coming with many different skin lesions which have different patterns. So we started working on multi-class classification, and we could produce a good sensitivity of around 80% for 50 common skin diseases. So although the total number of skin diseases runs into several hundred, but if you look at the patients coming to us, these 50 common diseases would cover more than 80% of the patients. And when it comes to primary care physicians, their ability to diagnose a skin condition. So more than 40% of the patients coming to primary care physicians are related to skin. And their ability to diagnose skin diseases as compared to dermatologists is just 40%. So, we were trying to bridge the gap because most of the dermatologists, they are centered in the big cities, and a large part of the country is devoid of dermatological expertise, and primary care physicians, they were not able to handle the situation. And the Google France data suggests that the most common health related problems which are searched on the Google are skin related. So people are quite concerned and they don't have access to skin health. So then when we worked on 50 skin diseases, we could reach to 80% accuracy, but we hit the ceiling. We couldn't go beyond it. So that's why we thought that it has to be a multi-model model. Means we cannot depend on just one technology to achieve the optimum solution for any kind of pattern recognition technologies, be it radiology, be it dermatology, or be it histopathology, or any other specialty which heavily depends on pattern recognition. So now we are working on multimodal model, and recently this Ministry of Education, we won the contest of Ministry of Education. They advertised one contest for AI in Healthcare Center of Excellence, and some 30 institutions participated in it. Eventually, it was given to, based on they gave us 6 months to perform, and then we got it on the basis of competition in collaboration with IIT Delhi. So here now we are going to implement, like, it is not just image but also the patient metadata, and if we can combine the two to produce a better outcome of a diagnostic assistant which can be incorporated in the clinical practice. So this is about our own work and our own future aspirations, but a lot has to be done. And another problem which we face is that creating a technology is one thing, but integrating it into the healthcare system is entirely another. Even if you produce a very good solution, unless it is not accepted by the medical fraternity or those who are end users, then it is not going to succeed. So this is what happened. We tested in 5,000 patients our application, and what we found is that the best performance was in the urban private practice, and then rural areas, and then in